Okay, let's unpack this. Imagine you've got a patient in your exam room. Maybe it's a cranky older cat, or maybe a dog who just seems uncomfortable, and the owner says, they haven't.
Yeah.
Well, they haven't gone.
Right.
Suddenly you're dealing with constipation, or potentially something much more serious like obstipation. It's such a common problem in practice, isn't it?
Oh, absolutely.
But as our source material shows, it's definitely not simple.
Not at all.
Today, we're doing a deep dive using an excerpt from a clinical veterinary text. It's actually a really valuable resource, gives a concise but a pretty thorough overview of this whole issue. Our mission here is to kind of cut through the noise, pull out the most critical knowledge from this text, the definitions, the surprisingly wide range of causes, the key diagnostic steps, and, the best treatment strategies specifically for you, the clinician listening in.
Yeah, getting right to the practical stuff.
Exactly.
Yeah.
This is about really solidifying your understanding of a problem you're going to face regularly, especially because, as the source points out, it's really common in older cats.
That's right. And what often looks like, a straightforward blockage can unravel into a pretty complex diagnostic puzzle.
Totally.
Managing these cases well, going from seeing the signs to figuring out the why and then picking the right intervention, it really relies on having a solid grip on the principles and the options, just like those laid out in this text.
So it's more than just getting things moving again.
Much more. It's about trying to stop it from becoming a recurring nightmare for the pet and the owner.
Absolutely. And to do that, we have to start by getting our terms straight, right?
Yeah.
The source is very clear on the distinction, constipation. It defines it as infrequent, incomplete, or difficult defecation, usually hard, dry feces. But what's key here, it says, is that initially it doesn't necessarily mean the colon's totally lost its mojo, its ability to move things.
Exactly. It's struggling, but there might still be some motility left. It's not necessarily broken yet, just inefficient. Of course. And if we think big picture, understanding that constipation is often the precursor, the step before obstipation, that's really vital.
Ah, okay.
Obstipation is the much more severe, intractable form. The source defines it as constipation that's basically failed to respond to your aggressive treatment attempts. Defecation is essentially impossible at that point.
So it's not just really bad constipation?
No, it implies a more fixed, unresponsive state, and that definitely changes your prognosis and usually dictates a more urgent, maybe even surgical approach. That distinction, that's a critical clinical takeaway from this text.
Okay, that makes perfect sense. Constipation, difficulty, obstipation, impossibility, even after you've tried things. So going back to constipation then, what's physically happening? Why do the feces get so hard and dry? What's the pathophysiology according to the source?
Well, the fundamental mechanism described is delayed fecal transit time through the colon.
Okay.
See, the colon's main job is absorbing water and electrolytes to form solid stool. When fecal matter just sits there for too long, the colon just keeps doing its job, keeps absorbing, leading to excessively dry, hard feces. Rock-like, sometimes. Initially, you might even see the colon trying harder, increased contractions, peristalsis, trying to push that blockage.
Right, it's fighting it.
Exactly. But, and here's the kicker, with chronic distension from all that retained feces, the smooth muscle in the colon wall can actually start to degenerate. It gets stretched out, loses its tone.
Oh, wow.
Yeah, and that's where you lose effective motility. The colon becomes kind of like a stretched out, flaccid bag. And those systemic signs we sometimes see, the lethargy, not eating, maybe vomiting, those often come not just from the discomfort, but from dehydration and potentially absorbing toxins from that stagnant fecal material. It's a nasty cycle.
That visual of the colon losing its tone, that really sticks. So how do we spot this in practice? What are the classic signs, and what does the source mention about signalment? Who gets this?
Okay, history-wise, owners usually report, reduced or totally absent defecation.
Right.
Pretty obvious. If the animal is managing to go, it's difficult, maybe painful, and the feces are hard, dry, often small little nuggets. Sometimes you'll see tenesmus, that prolonged, ineffective straining.
Yeah, the classic sign.
Which can occasionally result in passing small amounts of liquidy, mucoid, or even bloody stool around the main impaction. Don't let that fool you.
Good point.
Other nonspecific signs like occasional vomiting, reduced appetite, lethargy, they're common too, just because the animal feels generally crummy.
Makes sense. And on the physical exam?
The key finding, often, is feeling a large, firm, palpable mass in the abdomen. That's the impacted colon.
You can usually feel it pretty clearly.
Often, yes. In severe cases, it can even cause obvious abdominal distension. But beyond just feeling the poop, Your exam is crucial for hunting down the underlying cause. A thorough rectal exam is non-negotiable. Seriously. It can reveal everything from a foreign body or a stricture inside the rectum itself to external compression from things like prostatic enlargement in males, intrapelvic masses, or maybe a narrowed pelvic canal from an old fracture you didn't know about.
Wow, okay.
You might also find signs of painful anal sac disease, perianal fistulas, or even a rectal prolapse. Lots to check back there.
And the signalment details. The source mentioned cats.
Right. The text is clear. While dogs and cats can both get it, it is significantly more common in cats, particularly older cats.
That's a big flag.
Huge. It immediately makes you think about things like chronic kidney disease, which is rampant in older cats and leads to dehydration, a major contributing factor.
Absolutely. And connecting that back to the why those age-related changes may be idiopathic megacolon, they really lean towards cats, especially seniors.
Definitely weighted towards felines. But age isn't the only thing, of course.
No, not at all. And this is where that list of causes gets, well, extensive. This is why you need a systematic approach, right? The source gives a fantastic breakdown.
It really does. And it's worth spending a minute on these categories because they really guide your diagnostic plan.
Okay, lay them on us.
First up, dietary factors. Pretty straightforward, but common. Things they ate bones, too much hair from grooming, especially cats.
Hairballs, yeah.
Foreign material, sometimes even too much fiber if it's not balanced with enough water, or just plain inadequate water intake. That's a big one.
Dehydration again.
Always lurking. Then you have environmental factors. Lack of exercise can slow the gut,
Yeah.
but also stress, like being hospitalized in a small cage.
Or a dirty litter box.
Exactly. Cats can be incredibly fussy about that. Or just inability to posture comfortably due to arthritis or injury.
Okay, what else?
A huge one for us clinicians. Drugs. The list is longer than you might think. Anticholinergics, antihistamines, opioids, very common post-op problem.
Definitely see that.
Barium sulfate after studies, even stuff like sucralfate, antacids, kaopectylan, iron supplements, and diuretics, which cause dehydration. Need to check that med list.
Good reminder.
Then painful defecation or dyschezia. If it hurts, they won't want to go. This covers anorectal diseases, anal sacculitis, abscesses, fistulas, strictures, spasms, rectal foreign bodies, proctitis.
Lots of painful things back there.
Yep. And trauma fits here too, a fractured pelvis, or hind limb making posturing agony, or a bite wound or abscess near the anus.
Okay, makes sense. Keep going.
Next, mechanical obstruction. This can be extraluminal stuff outside the colon pressing on it, like a badly healed pelvic fracture narrowing the canal.
Pelvic stenosis, yeah.
Prostatic enlargement or cancer in male dogs. Intrapelvic tumors, enlarged lymph nodes back there. Or it could be intraluminal intramural, so inside the colon wall or lumen. Things like tumors or polyps, strictures, foreign bodies stuck in there, rectal diverticula, even congenital defects.
Right.
A perineal hernia is another mechanical issue where guts bulge out beside the rectum. And rectal prolapse is pretty obvious obstruction.
Okay, still more.
Yep. Neuromuscular disease, big category. Could be central nervous system, like paraplegia from a spinal cord injury or disc disease, or even certain brain issues like lead toxicity or, sadly, rabies. Or peripheral nervous system stuff like feline dysautonomia, or damage to the sacral nerves, often from those tail pull injuries in cats. And of course, the big one, colonic smooth muscle dysfunction itself, most famously idiopathic megacolon in cats where the muscle just quits.
Right, the floppy colon.
Exactly. Lastly, metabolic and endocrine disease. These can impair smooth muscle function systemically. Think electrolyte imbalances or muscle weakness, hyperparathyroidism, hypothyroidism, hypokalemia, huge in CKD cats again, or hypercalcemia.
Okay.
And just general debility from any severe illness causing muscle weakness, dehydration. Maybe they're just too sick and weak to posture properly.
Phew. Okay. That list really drives home why you need a thorough workup. It's rarely just constipation. And the source mentions specific risk factors too.
Yes, beyond the general causes, it flags certain predispositions. Manx cats, because of their congenital tail sacral bone issues affecting nerves, specific drug therapies, as we listed, any metabolic disease causing dehydration. Feline dysautonomia,
Okay.
intact male dogs, they're prone to perineal hernias, and benign prostatic hyperplasia. Interestingly, castrated male dogs are actually more likely to get prostatic neoplasia. And dogs with perianal fistulas, knowing these helps you filter that huge list of causes.
Definitely helps prioritize. Okay, so we've got the picture of what it looks like, the enormous range of why it might happen. How do we actually figure it out? The diagnostic workup, where does the source guide us?
Well, the very first step And it's critical, but sometimes missed, is differentiating true constipation from things that just look like straining to poop.
Ah, the lookalikes.
Exactly. Are we dealing with a defecation problem or a urination problem? Dyschezia or tenesmus, that straining can be due to colitis or proctitis. Key difference: stool consistency and frequency. Colitis often means more attempts, small amounts of loose, maybe mucousy or bloody stool, and your rectal exam won't find hard-impacted feces.
Okay, good distinction.
The other big mimic is stranguria, straining to urinate. That points you towards cystitis or urethritis. You'll see frequent squatting, maybe only dribbles of urine, maybe crying out. And your urinalysis would show hematuria or pyuria. Checking for a big hard bladder is key there, too.
Right. Rule out urinary first.
Absolutely. Once you're pretty sure it is a defecation issue, then you move to labs. CBC, chem panel, urinalysis. Often they're unremarkable in simple acute cases.
But still necessary.
Essential. Because you're hunting for those systemic underlying causes we talked about. You're looking for red flags.
Yeah.
Hypokalemia, major factor in cat GI motility, especially with kidney disease. Hypercalcemia messes with smooth muscle. PCV and total protein tell you about hydration status. A high white count might point to inflammation or infection related to the cause, an abscess, fistula, prostatitis, and seeing white cells or blood in the urine could point to prostatic issues bleeding into the urinary tract.
Got it.
Based on those results, the source suggests maybe running a thyroid panel if cholesterol is high, or a PTH assay if calcium is high. Follow the clues.
Makes sense. What about imaging?
Imaging is often where you get the money shot. Abdominal radiography x-rays, that's your crucial first step. It confirms the impaction, shows you how severe the colonic distension is.
And finds causes?
Often, yes. It can reveal specific things like swallowed foreign objects, evidence of a mass pushing on the colon, a malunited pelvic fracture narrowing the canal, a dislocated hip making posturing hard, obvious hernias. Super useful. The source also mentions that after you've given enemas to clear some stool out, sometimes doing a pneumocolon, putting air in the colon via the rectum, and taking more x-rays can help outline things inside the colon, like polyps or strictures, better.
Oh, interesting technique.
Yeah. And ultrasound is also valuable, especially for looking at things outside the colon, like masses pressing on it, or getting a really detailed look at the prostate.
Okay. Any other procedures?
Well, if you suspect something inside the colon, like a polyp or a stricture, or need to know exactly what a mass is, you might need colonoscopy.
Right. Look inside with a scope.
Exactly. That's you visualize the inside of the colon and rectum. And the source is emphatic here. Biopsy specimens should always be obtained during colonoscopy. You need that tissue diagnosis to know if you're dealing with inflammation or cancer or something else. Critical for treatment and prognosis.
Absolutely. That's a really solid diagnostic roadmap. Okay, so we've done the workup. We know what's going on. Maybe we even know why. How do we treat this mess? What's the approach the text recommends?
The absolute core principle, number one, if at all possible: remove or fix the underlying cause.
Makes sense.
If it's a drug, stop it. If it's pain from arthritis, manage the pain. If it's the prostate, address that. You get the idea. For patients that are truly obstipated or really dehydrated, the source notes that inpatient care is usually needed. They need more intensive support.
Okay. So hospitalization, what's the first step there?
Nursing care starts with the most basic need: rehydration. These guys are often super dehydrated from not eating or drinking, maybe vomiting, and definitely from that colon sucking every last drop of moisture out.
Right.
5E fluids are best for getting fluids in fast, but subcutaneous balanced electrolytes are also really helpful, especially in cats where long-term IV access can be a pain.
Yeah, CFQ fluids are great for cats.
And critically, supplement potassium if they're hypokalemic, which again is super common in cats with kidney disease contributing to constipation.
Got it. Fluids first. What about diet?
Dietary management can help, but you got to be smart about it. Bulk forming agents, things like psyllium fiber, metamucil, canned pumpkin, prescription high fiber diets can increase fecal volume and stimulate motility if the colon still has some function. Right. Because the source adds a huge caveat.
Yeah.
In severely distended colons or true megacolon, adding more bulk can actually make things worse.
Oh, right. More volume in a bag that can't empty.
Exactly. In those cases, a low-residue diet might actually be better initially, just to reduce the amount of stool being produced while you work on emptying the colon.
Okay, that's an important distinction. Anything else on the nursing side?
Encouraging activity is mentioned. Just getting them up and moving around can help stimulate gut motility naturally.
Makes sense. Walk the dog, play with the cat a bit.
Yep. And client education is massive for this condition. both for managing the acute episode and, more importantly, for long-term prevention.
What do owners need to know?
They need to understand the right diet, the importance of exercise, and for cat owners, daily monitoring of the litter box. Catching problems early makes a huge difference.
Definitely.
And teaching owners how to give subcutaneous fluids at home. That could be a total game changer for managing hydration and preventing recurrence in cats prone to chronic constipation.
Huge quality of life improver. Okay, now what about actually getting the poop out, the interventions?
Right. If fluids and diet changes aren't cutting it, or if you have severe obstipation, manual removal is often the next step. This means digitally, through the anus.
Under anesthesia?
Absolutely, under general anesthesia. And crucially, after the patient is well rehydrated, trying to dig out rock-hard feces from a dehydrated, awake animal is just painful, traumatic, and usually doesn't work well.
Yeah, don't do that.
Please don't. For those really tough cases of recurring obstipation that just aren't responding well to ongoing medical management and are ruining the pet's quality of life, the source notes that subtotal colectomy, surgically removing most of the colon, might be the best option, especially for cats with idiopathic megacolon.
The big surgery.
It's a salvage procedure, but can be very effective for the right cases.
Okay, and this brings us to medications. This is where the details really matter for clinicians. What are the options the source lists, and maybe even more critical, what are the absolute don't leads?
Okay, let's look at the pharmacy toolkit based on this text. For loosening the stool, emollient laxatives are a common starting point. Docusate sodium, or calcium.
Stool softeners.
Basically, yeah. The source gives dosages. 50, 100 milligrams orally every 12-24 hours for dogs, and 50 milligrams orally every 12-24 hours for cats.
Okay.
Stimulant laxatives like bisacodil can actually induce colonic contractions. The dose is about 5 milligrams per animal orally every 8-24 hours. But the source has a huge warning here. Use extreme caution and make absolutely sure there is no mechanical obstruction before you give a stimulant.
Right, you don't want to force motility against a wall.
Could cause rupture. Very bad. Then you have saline laxatives, like polyethylene glycol solutions, often mixed with poorly absorbed salts. These can be super effective, sometimes given as an isoosmotic mixture through a nasosophageal tube over several hours to really flush the colon out.
The go lightly type preps?
Exactly. Disaccharide laxatives like lactulose are very common osmotic laxatives. Doses around 1 millivol per 4.5 kilos orally every 8-12 hours, adjusting based on stool consistency. Plus water into the colon.
Okay, what about enemas?
Enemas are often necessary to break down and flush out impacted feces. Warm water enemas are standard. You can add a tiny bit of mild soap or docusate sodium, BUT, and this is a massive safety point the source hammers home. Sodium phosphate retention enemas, specifically fleet enemas, are absolutely contraindicated in small animals. Cannot stress that enough.
Why? What happens?
They can cause severe, potentially fatal hyperphosphatemia and subsequent hypocalcemia. Just don't use them, ever.
Got it. Big red flag. Fleet enemas equals NO.
Correct. Suppositories using glycerol, bisacodil, or docusate can be an alternative for milder cases or maybe as follow-up care.
Okay. And motility drugs?
For motility support, especially if you suspect early megacolon or ongoing poor motility modifiers are used. Cisapride is the main one mentioned.
The prokinetic.
Right. Dosages. Dogs, 0.3, 0.5 milligram or orally, Q8, 12 or out. Cats, 2.5, 10 milligrams per cat, orally Q8, 12 era. But again, use with caution, and it's specifically contraindicated if there's any kind of obstruction.
Okay. Now let's hit those contraindications again, the absolute no-nos from the source.
Let's reiterate. Lubricant laxatives like mineral oil or white petrolatum, not recommended.
Yeah.
Huge risk of fatal lipid aspiration pneumonia because they have no taste. Animals can inhale it easily.
Scary.
Very. Fleet sodium phosphate enemas, absolutely contraindicated. We covered that. Anticholinergics, they slow the gut, make it worse. Diuretics cause dehydration, make it worse. And the source specifically points out that metoclopramide, Regalon, doesn't really affect the colon, so it's not helpful for this specific problem.
Okay, clear list of things to avoid. Any other drug options mentioned?
The source briefly touches on a couple of alternatives, or maybe future options. Ranitidine and misoprostol has shown some effects on colonic muscle contraction in vitro, maybe newer cisapride-like drugs down the line. It also highlights one pilot study showing clinical improvement in cats with chronic constipation idiopathic megacolon using a specific probiotic blend called SLA51.
Interesting, the microbiome connection.
Yes, suggests the gut microbiome might play a role sometimes, which opens up other avenues, possibly.
That's incredibly useful clinical detail, especially those contraindications. So once the immediate crisis is over, what about the long haul? Follow-up, Prognosis, what does the source say?
Long-term patient monitoring is key.
Sure.
You need to track how often they're defecating and what the stool consistency is like. The source suggests checking at least twice a week initially,
Okay.
then maybe weekly or biweekly depending on how they're doing with their ongoing therapy, whether that's diet, meds, or both.
Yeah.
You adjust as needed.
And prevention.
It circles back to that client education piece. Keep pushing the appropriate diet, enough activity, and hydration. Hydration especially for cats. Subcutaneous fluids at home if needed. Proactive management is often the name of the game for chronic cases.
Right. What are the risks if it keeps happening? Complications.
The source lists potential complications.
Yeah.
Chronic or recurrent issues can, unfortunately, lead to acquired megacolon, where the colon gets permanently damaged and floppy, even if the original cause wasn't neuromuscular.
Oh.
Overusing laxatives or enemas can swing things the other way and cause chronic diarrhea. Improper technique during manual removal or enemas, or even just the constant pressure from rock-hard feces can damage the colonic lining. And all that chronic straining or perineal irritation can sometimes even lead to fecal incontinence down the road.
Not good outcomes. So what's the general outlook? Prognosis.
The expected course and prognosis really depend heavily on that underlying cause. Generally, the source describes it as fair to good if you get an early diagnosis and start intervention promptly. If you can find and definitively fix the root cause, like removing a foreign body or managing prostatic disease successfully, the prognosis for long-term resolution is obviously better.
But if you can't?
Right. If the underlying cause is something chronic, progressive, or idiopathic, like feline megacolon, then recurrence is definitely possible, even likely. Managing those flare-ups just becomes part of the long-term care plan. It's often a condition requiring ongoing management, not just a one-and-done fix.
Wow. That really does cover the waterfront, doesn't it? From feeling that hard colon on exam all the way through managing potential lifelong issues. We've taken a really detailed pass through this clinical text excerpt, highlighting the definitions, digging into that complex web of causes, walking through the essential diagnostic steps, and outlining the treatment approaches, including those really crucial medication do's and don'ts.
It certainly does highlight that while the sign itself, difficulty pooping, seems simple, the potential causes and the management strategies are actually quite diverse. It really demands that thorough, systematic approach grounded in the kind of solid knowledge this source provides.
Absolutely. Having this information kind of distilled and ready to go can make a huge difference when you're faced with that very common clinical situation. Allows you to move confidently from the cat hasn't pooped to actually building a targeted plan.
Yeah, exactly.
And, thinking about the bigger picture, especially managing these often chronic cases, particularly in cats, it kind of raises an important question for all of us listening, right? Considering that potential for progression to acquired megacolon, what subtle clues or risk factors could we maybe focus on even earlier to try and predict which patients are most likely to become chronic or really tough to manage?
That's a great question.
And how might our initial management choices maybe differ if we suspect a higher risk of long-term problems versus what seems like just a simple acute case, something to definitely mull over as you approach your next constipation case?
Indeed. Food for thought.
Thank you for joining us for this deep dive.